Very good evening to you. Still with ENCA as we continue our conversation with Professor Salim Abdool Karim, the Infectious Disease Specialist who chairs Government's Advisory Committee on the Coronavirus. Prof, we were taking questions that are coming in from our viewers via social media, and I've got one here from AJ Williams ZA who asks, how many of the 93 deaths that we've reported so far were people living with HIV and AIDS or active TB patients?
Actually, that's a very good question. As far as I'm aware, there is one patient who was HIV positive. I actually do not know if there are any other patients with HIV. And as far as I'm aware, and I stand to be corrected, there were no patients with tuberculosis. What is becoming apparent is that most of our deaths occur in the older age groups, and most of them have some kind of comorbidity, whether it's diabetes or heart disease, and that seems to be playing out exactly in the same way that we saw from the information we received from China and from Italy and from the US.
Prof, some of the thinking around the immune system, there's some sort of latest research. Of course, it's all new, so it's not all of it is tested. But the issue around how this virus interacts with the immune system seems to be something that scientists are looking at now. You, of course, were at the forefront of South Africa's research into AIDS, and you studied the immune system. So I'm wondering if you are looking at how COVID affects the immune system and looking at HIV, of course, which attacks the immune system, and seeing any similarities, perhaps.
So the way HIV works and the coronavirus works is completely opposite. There's almost nothing in common between HIV and the coronavirus. In fact, the only thing I know that's in common is they both are single-stranded RNA viruses, but there's very little else. But let me explain just at a very simple level what this coronavirus infection actually means and what the immune response is. So the virus itself enters mainly through the nose or the throat or the eyes, where there's these cells that have a particular receptor. It's called the ACE receptor. That receptor is the point at which the virus attaches. And it's called a spike protein. So you know that it's called coronavirus because it looks like a crown on the outside. It's got these spikes. So those spikes go and attach to the cells. They then enter the cell and they make copies of themselves. And in making copies, they then burst out and they break the cell. It then goes into the lung. And when it gets into the lung, it enters into the lung cells in the same way and makes copies of itself. In a small number of people, roughly around 5% of patients, they seem to have a very severe immune reaction. What happens is that their body goes into overdrive. It releases large amounts of these little proteins called cytokines. And they create something that's called a cytokine storm. And the cytokines are little signals that get the immune system into gear, and so you end up with huge amounts of immune response in the lung, and that's what causes this difficulty to breathe, and they cannot exchange oxygen, and we need to put them on ventilators. So put it in very simple terms, it's really the imbalance between the immune response and the threat that is posed. And we don't understand yet why that's the case. But you're absolutely right. That is what we need to study. That's what we need to figure out. How do we prevent this immune response from going into overdrive and creating the storm? What drugs could we use? What therapeutic approaches could we use? And that's where a lot of the medications are targeting.
And that's where a lot of the theories are coming out. One of the things that I know the WHO is also saying it's a maybe is that certain HIV drugs may assist, and it's not confirmed because, of course, there haven't been enough people with HIV and coronavirus, I think. It may assist with coronavirus. As someone who understands AIDS so well, do you think that there might be some hope that some of the AIDS drugs could provide some sort of protection from COVID-19?
Well, there were 3 drugs that were thought to be among those that were most likely to be helpful. The one was an anti-HIV drug called lopinavir. It's administered with a booster of a drug called rotinavir. So if you look at the drug lopinavir, we actually use it in second-line treatment in South Africa. It's not a very commonly used drug, but it is available. So that drug was studied early on in China, and a study that was published in the New England Journal of Medicine basically showed that it didn't help. It didn't hasten improvement. It didn't reduce hospital stay. So we know that the anti-HIV drug, lopinavir, doesn't really help. There's another drug called remdesivir. Remdesivir was actually developed for SARS, and it was kept on the shelf because by the time it was developed, the SARS epidemic disappeared. So that drug has been tested, and just yesterday, the journal Lancet has released some data that suggests that remdesivir does not help. It does not improve outcomes, doesn't reduce hospital stay, so it looks like the 2 drugs that we thought would most help are not helpful. The third is chloroquine. Now, chloroquine doesn't actually affect the virus. It doesn't kill viruses. The way it's thought to act is it's thought to act through modulating the immune system, because it's used for lupus and so on. It's not a drug we use anymore for malaria because malaria is resistant to it. This particular drug has now been in studies, in various studies, and some of the early results have come. And they've been really disappointing. They have not provided us with any indication that there would be a benefit. In fact, the high dose of chloroquine has been shown to be harmful. It actually leads to heart attacks, or a particular form of a change in the way in which your heart functions. So I think at this stage, there's been many studies. All of them have been disappointing, and there is no evidence that any treatment is beneficial at this time.
This is really worrying, and we're still on the race to get a vaccine. I want to get your input on 2 new sort of symptoms that are being picked up on. One is this thing called silent hypoxia, which is low oxygen in the blood, and what some doctors, I think, in the US are saying to show how unpredictable this virus is that people actually have very low oxygen in the blood, but they're not displaying the behavior that they would expect. They'd expect someone with extremely low oxygen levels to be almost comatose, but these people are not. And then the other thing is that 70% of people admitted to hospital for COVID-19 in the United States, this is according to the American Medical Association, don't have fever as a main symptom. So what are those 2 pieces of information, research, and findings of people who are at the front line of the disease telling us about how we should approach testing and screening?
So they're quite right. We have been learning a lot from the experiences of other countries. When we initially looked at the data from China, fever was the #1 presenting feature. The data from the US suggests differently. But there's quite a big difference in the patients that are being seen in the US versus those that are being seen in China. In that in the US, many of the patients have obesity as one of the compounding factors that's increasing their risk. The issue of hypoxia, because of the silent way in which this virus enters the lung and grows in the lung and leads to changes in the lung, what happens is that the exchange of oxygen from the air into the blood vessels in the lung is compromised. When we take an X-ray, we see a very typical kind of picture called a ground glass feature. But now we're seeing atypical features. Not everyone has this ground glass. But one of the things we're noticing is that even though they don't have marked changes, they have a challenge in being able to exchange oxygen. And so this hypoxia is quite a common occurrence. And in fact, what happens is that in some patients, they can deteriorate quite rapidly. So we know these clinical features, and many of the doctors, we've been having grand rounds with them. We've been sharing experiences amongst all of the doctors. And part of that is that we are learning as we go. But what has it told us about how to treat these patients? We have a much better understanding about how to triage them, how to manage them initially, and how to only put them onto ventilation when they absolutely require it. And in the way in which we manage them, one of the key things is to ensure that we maintain oxygenation. And the reason for that is because that can change quite quickly. So we've been establishing these protocols, we have guidelines that we make available, and we update it as new evidence becomes available.
Well, thank you so much. And I think the 6 weeks that the lockdown has brought us also gives us time to assimilate all that information. Thank you so very much for your time. That was Professor Salim Abdool Karim coming to us live from Durban this evening.